بس عشان في مشكلة كده.
هيبدأ امتى؟ مش بيبدأ. Good afternoon, ladies and gentlemen. First of all, I would like to thank the organizing committee and my dear professor, Dr. Lamia Estrogi, for her kind invitation. Our topic is about artificial intelligence in glioma imaging. I propose to consider a question. Can machine think? The answer is yes if we use AI or artificial intelligence. Artificial intelligence is a broad term which includes machine learning and deep learning. AI means the computer ability to perform tasks that are similar to those performed by humans. Intelligent machines will replace human capabilities in many areas, especially in radiology field. Machine learning is the study of computer algorithms that allow computer programs to automatically improve through experience. Deep learning depends on artificial neural network, which is a mathematical representation of the human neural architecture. As we see here, this is the brain, the human brain neuron, and this is the perceptron of the artificial neural network. Artificial neural network composed of multiple layers, input layer, multiple hidden layers, up to 20 layers, and output layer. CAD systems include computer-aided detection for detecting and locating the abnormal area, computer-aided diagnosis for diagnosis and classify benign or malignant tissues. Applications of AI in gliomas include grading, tumor segmentation, predicting glioma genomics, preoperative planning, intraoperative treatment planning, histopathologic diagnosis, radiotherapy, post-treatment follow-up, and outcome prediction. A novel system for precise glioma grading. Our work was done in Radiology Department, Mansoura University, under supervision of Professor Lamia Estrogi, head of the Radiology Department, and late Professor Ahmed Abdel Khaliq, may God bless his soul. In collaboration with Bioengineering Department, Leosville University, under supervision of Professor Ayman El-Baz. Annually, from 5 to 10 per 100,000 people are in danger of contracting glioma. It represents about 30% of brain tumors. It is the 10th leading cancer cause of death in the USA. It has median survival less than 15 months and 5-year survival rate less than 10%. WHO classification of glioma include 4 grades. Grade 1 and 2 consider low-grade glioma, and grade 3 and 4 consider high-grade glioma. The current diagnostic tools include biopsy, which is the gold standard, MRI, and advanced MRI submodalities like diffusion, perfusion, and MRI spectroscopy. Our study was conducted on a total 99 pathologically proved gliomas classified as follows: 13 patients with grade 1, 22 patients with grade 2, 22 patients with grade 3, and 42 patients with grade 4. Conventional MRI protocol was done for all patients, include pre and post T1 weighted image, flare, and diffusion weighted image. Segmentation was done on the tumor only in T1 and diffusion weighted image, and the tumor with the surrounding edema in flare images. Here, our proposed GG-CAD framework, or glioma grading computer-aided diagnostic framework. It composed of 3 main steps. First step is glioma tumor pre-processing. We choose diffusion, flare, and contrast-enhanced image. We do proper segmentation for the tumor, and then we construct 3D image. The second step is feature extraction and selection. It includes morphological feature, texture features, and functional features using certain programs. I will discuss it soon. The third step includes these features get to the input layer, then pass through multiple hidden layers to give us the final diagnosis from the output layer and classification the glioma into 4 grades. Step 1, which is glioma tumor preprocessing. The more accurate the segmentation is, the more precise future extraction will be. Binary masks were applied over the gray level DICOM image to construct 3D glioma objects. These 3D objects are then used for extracting the features. Feature extraction include texture, morphological, and functional features. Texture feature extraction, first order texture gives precise description for the heterogeneity and homogeneity of the detected gliomas. Second order gray level co-occurrence matrix accounts for how frequently a pair of gray level intensity values appear adjacently within the object. Second order gray level run length matrix examines how many times each gray level value appears successively in a run of voxels. Morphological feature extraction based on 3D histogram of oriented gradient and estimating the glioma volume relies on the hypothesis that gliomas with high grades have more aggressive growth rates, more complex, rough, and irregular shapes than those with lower grades. Functional feature extraction by estimating voxel-wise apparent diffusion coefficients and Gaussian slopes. As we all know that functionality of the gliomas has effect on the imaging. Feature integration and classification. Aforementioned individual features are then integrated together to be fed to a multi-layer Perceptron artificial neural network classification model toward getting the final diagnostic decision. This is our results. The overall accuracy of the GG-CAD system is about 95%. Conclusion. The proposed GG-CAD achieved overall accuracy about 94.6%. Results hold the promise of the developed GG-CAD system as a non-invasive diagnostic tool. It has many advantages in comparison with previous studies. These advantages include precisely identify glioma into 4 grades instead of low grade and high grade, functional features incorporated for a better diagnostic performance, the first system to integrate novel 3D apparent features, volumetric features, 3D texture features, and functional features extracted from multimodal MRI images. What is our future work is computer-aided prediction system for correlation and pathological diagnosis, for correlating the pathological diagnosis with the treatment response. And thank you.
Thank you, Dr. Ahala, for your nice presentation. You are excellent in everything.